Hello, my name is J.P. Lee. I'm a professor emeritus from UC Davis. Today I'd like to talk about low wages as occupational health hazards. Some of the following is based upon a paper I published with Robert DeVoglie in the Journal of Occupational Environmental Medicine in 2016. The history of occupational medicine has been characterized by ever-widening recognition of hazards, from fires in 1911 to asbestos in the 1960s to job strain in the 1990s. Current thinking about divides hazards into three categories: physical and mechanical, biological and chemical, and psychosocial. The last of these, psychosocial, has been the most recent category added to the list. Psychosocial hazards include precarious work contracts, job insecurity, organizational injustice, long work hours, and job strain. My purpose today is to argue that low wages ought to be added to that list. According to two prominent workplace sociologists, broad consensus exists that wages are a fundamental dimension of job quality. The prominent labor economist agrees. In a national British survey, people viewed wages as one of the two most important aspects of jobs, the other being job security, and both ranked higher than the use of initiative, the work itself, and hours at work. There are reasons to look at low-wage workers. First, low-wage workers comprise a large and growing share of the American workforce. Who are they? Let's look at who would benefit from the federal minimum wage being raised to $15 an hour. A total of 34 million workers would benefit, including 30 million who are adults, 20 million full-time workers, 20 million women, 9 million parents, 5 million single parents, 6 million workers living in poverty. There's a second reason to look at low-wage workers, because they're disproportionately a share are women, African Americans, and Hispanics. The third reason, a disproportionate share, are COVID essential workers: nursing aides, hospital orderlies, home care aides, grocery workers, cashiers, gig drivers, meat packers, sanitation workers, food preparation workers, and farm workers. The fourth reason, stagnant or falling inflation-adjusted wages for a large majority of the American workforce, has been a major contributor to the rising income inequality within the U.S. since the mid-1970s. The fifth reason is that wages are likely to continue to fall as our employment rate is now at 15%. This chart shows the wage distribution over time and how it's been becoming more unequal. This is the top 5% of wage earners from 1979 through 2013. Here's the 50th percentile. Here's the lowest 10th percentile. What's the theory regarding wages affecting health? There are two pathways for one is affordability. The other is psychosocial. Affordability simply indicates that higher wages allow workers to better afford goods and services, including higher quality food and water, cleaner and safer neighborhoods, gym memberships, healthcare, and medicines. There are two psychosocial streams for pathways. One involves job satisfaction. Economists provide evidence that low wages negatively affect job satisfaction. Epidemiologists provide evidence that low job satisfaction predicts poor physiological and psychological health. The second psychosocial stream involves social status. Humans are a social species. For better or for worse, mostly for worse, we compare ourselves to others. We value the respect of others, which partially is determined by our wages because they convey information about our position in the socioeconomic hierarchy. Much of this is written about in Michael Marmot's book, Status Syndrome. Both psychosocial streams suggest that higher wages should improve health. What's the evidence that wages can have health effects? There are problems with the colossal number of studies which show the correlation between low income and poor health. How do we know it's not poor health that results in low income? Well, the best evidence comes from minimum wage studies. Increases in minimum wages are natural experiments. They rule out the causality running from health to wages. We cannot argue that good health of low-wage workers in, for example, New Jersey leads New Jersey legislators to raise their minimum wages, whereas bad health of low-wage workers in Pennsylvania results in Pennsylvania legislators not raising their minimum wage. We did a literature review of 33 studies on minimum wages in health, published in Preventive Medicine. Most of these 33 were of low quality, however. For example, many studies included all employed people, that is, people making $100,000 a year or more, were included in their samples. But minimum wages have no effect on people making $100,000 a year. We therefore restricted attention to 15 high-quality studies that focused on low-wage workers. There were over 20 possible outcomes in these studies, including obesity, smoking, birth weight, absenteeism, and self-rated health. There's only one consistent finding across many of these studies, and that is that increased minimum wages led to reduced smoking. An increase of minimum wage, a $1 increase in minimum wage was associated with a 1.4% decrease in the prevalence of smoking among low-wage workers. So in conclusion, there's mountains of evidence in economics on minimum wages. It's been going on for over 60 years. Public health research on minimum wages is only about 3 to 4 years old. It's minuscule by comparison. I predict wages and health will be a booming area for research in the coming years.